Welcome to the Osmosis webinar on clinical learning from a distance. I'm Katherine Johnson, Senior Director of Institutional Engagement at Osmosis. Our agenda for today will be to go through welcome and introductions, which we've started now. We'll do a quick recap of how we got to this place now with COVID-19. And then we'll walk through some approaches to distance learning, including simulation and teleclerkships or teleclinicals. Today's presenters are Dr. Amin Azzam, who is a psychiatrist and associate professor at UCSF Berkeley, and Dr. Tackett, who's an associate professor at Hopkins.
Hello, everyone. I'm broadcasting live from outside of Baltimore. I've got a three-year-old and seven-year-old boys downstairs, just to kind of show you how we're doing it. Social distancing. That's Theodore's little desk. That's our first grader. That's where he's doing his homeschooling. I kicked them out of the room so that I could speak to you. But if you hear any noise or anything like crashing or breaking, that's them. It's probably them. So just to put, so like I said, I'm a general internist. I know a lot about medical education and medical schools. Do recognize that a lot of you who are joining us may not be from medicine. I think a lot of the principles that we're going to share with you will apply to your own educational work. But at the same time, we want this to be interactive. We want everybody to be sharing their own experiences because frankly, nobody's an expert in what to do with our current circumstance. And so the more you guys can share with us and with each other, I think the more everybody will get out of the session. So I'd like to just begin by putting things into context. So on New Year's Eve, whenever many of us were probably having a good time and we're carefree, that was the day that the WHO was informed of a so-called pneumonia of unknown cause from Wuhan, China. And in January, it started to spread. You can see that Thailand was the first case outside of China. It was in the US as early as January 19th in Seattle. And then things kind of conflagrated from there in terms of a public health emergency, global pandemic. And then by St. Patrick's Day, the US accrediting authorities for both allopathic and osteopathic medicine sent out declarations essentially saying all students should stay at home, regardless of whether you were in a clerkship setting or in a pre-clerkship or non-clerkship setting, you got to just stay home. So that presented big challenges for medical schools in terms of how do we keep students learning clinically whenever they can't be in the clinic. So where we are today, this impacts approximately 30 to 50,000 medical schools in the U.S. alone. We surveyed so-called OMFs, the Osmosis Medical Education Fellows. So this is 67 students who are in a program that Osmosis administers. They come from 55 schools across 18 countries, and we asked them how their schools were adapting to coronavirus and social distancing. And every one of the students except the single student who was from a school in Samoa, which is an island that actually, at the time we sent the survey on March 20th, didn't have any COVID cases diagnosed, one of the few places in the world. That everybody else, though, their schools had told them to stay home and that there was no more student presence in the clinic for learning purposes. So again, this has not ever happened before. I think, today, one thing we can reflect on is that if it ever were to happen, this is about as good of a time as any for it to happen, given the technology and the opportunities we have to keep students going, despite the fact that, again, they can't have a physical presence in the clinic. So as I started thinking about just generically and broadly approaches to clinical learning at a distance, the way it made sense to me to think about it was there are sort of simulated learning experiences, and then there are sort of true learning experiences that are done at a distance. So phrasing these as teleclerkship or teleclinical kind of experiences. So in the big category of simulated clinical learning, you can actually do quite a lot. So there are resources out there to help students clinical reasoning. There are plenty of simulated clinical cases that students can work their way through to hone their thought processes. There are resources out there for diagnostic skills, like Visual DX is a popular one, but there are like dermatology specific ones and other specialty specific ones to improve student skills in visual diagnosis in particular. There are dedicated curricula for communication skills, and this can also be simulated in fancier ways, and Amin will probably speak to this a bit in terms of how you can sort of remote into a simulated patient experience. And then you can even go as far as to assess some physical exam skills at a distance. So the virtual OSCE is something that is being picked up more and more out of necessity during COVID times in medical schools. So these are all simulated. So again, there's no real patients here. These are sort of out of the box kind of solutions, or so that's simulated clinical. The teleclerkship is, I think, something new and not being done a lot and not being done enough from my own perspective. And so again, the categories as they made sense to me, where there's sort of participating in true telehealth practice. So, like teleradiology, there are plenty of current radiologists who currently work from home or work on a boat or wherever they are and have a nice lifestyle. And they're doing the exact same work and billing in the same way that a radiologist would if they were stationed in a hospital. And similarly with telepathology, their billing practices in particular, they're able to look at a slide anywhere and it's the same billing code. And so it's essentially, again, they don't need to be at a given location. Telemedicine visits in the ambulatory setting have been in place now for quite some time. And so these are actual patient visits and students can participate in those. And then there's several categories of provider-to-provider consultations, and that's what this chart depicts in a way on the right. And so these come in, again, different shapes and sizes. And so this is when like a provider might ask for a second opinion on a radiology or pathology specimen, or they might ask for a written second opinion where they send documents in a so-called store and forward manner, and then the specialist provider writes a report to answer their clinical questions. Even something like telestroke, which is more emergent, is a type of sort of provider-to-provider telemedicine modality. So that's just what I mean whenever I mention that. And again, I think students can participate in these in a similar way that they could participate in clinical consultative electives. I think the place where a lot of schools are trying to innovate more is in what I'm terming here tele-rounding. And so there are examples from Hopkins actually, where the students can round in the ICU remotely with there's a video, you can look it up online, where there's a Hopkins critical care doctor. He puts an iPhone strapped over top of his COVID sort of face mask, and then he kind of walks around, and the students can sort of see through his lens what's going on rounds, and they can also participate. And then I'll share one example of a wards elective for internal medicine, where students are similarly trying to pre-round on their patients, rounding with the team, and then doing follow-up work from home. And then something I haven't seen, but I would imagine it's feasible, is tele-scrubbing. So, one challenge is what do you do when you don't have access to an operating room, or some other, if you're in a procedure-based kind of clinical learning experience, how do you keep learning? Because it would seem like you really need to be there for the hands-on part of it. But again, my surgeon friends tell me that routinely at surgery conferences, they have sort of live streaming of surgeons describing what they're doing, which would not be that much different in my mind from like a medical student or some other student standing in the OR looking over the surgeon's shoulder, as they mostly do now, and kind of asking questions or being pimped, to enhance their understanding of anatomy and the procedure. So again, these are just to provide you with a framework, like a manageable way to kind of think about how we can deal with this, the simulated clinical learning, and then so-called teleclerkship or teleclinical. So we'll just talk through a few examples, and then we're going to, I think, pass it on to the group to share their examples. So this is the one that I'm most familiar with. This is literally just got off and running in the last week. So the pilot was over the last week, and they're going to formalize it into an elective. So the students who participate are people who have already done their general medicine clerkship, and then would be sort of eligible for an advanced clerkship or a sub-I. And so the people's faces here, this is Amit Pawa and this is Danelle Kayea. So they're the people who are actually making this work in the hospital, Johns Hopkins Hospital and Johns Hopkins Baby Medical Center. So what a student can expect, and what they've done over the last week is they get up and roll out of bed and sit in front of their computer, and they pre-round. And so this is similar to what they would do if they're sitting in the workroom. They look at Epic. They can actually call the patient and speak and take a brief history. If they're able to manage it, they can synchronize with the intern and be there when the intern's present and do some sort of physical exam, and then check in with the intern before rounds about what the plan for the day would be. Then they participate in rounds. They just do it remotely through Zoom. And so they can present on their own patient as they would, and then also kind of listen to what's going on with the other patients, ask questions, be asked questions, and keep learning that way. If it's an admitting day, then they are eligible to admit a patient, again, via Zoom. And then they can even put in admission orders into Epic because they have remote access there, and they can be co-signed by the resident. And then if there's no admitting, then they would just do their general tasks as they normally would. Again, this can be calling the patient, checking in with the family, checking in with outpatient providers, doing an extra effort with medication reconciliation, extra education for the patient. They can do literature reviews to teach the team and provide sort of the pearls that a lot of is common for workrooms in the afternoon. It's pretty much thinking about whatever they were doing before and how much of it can they do. And when we thought about it and started working on it, you can actually do almost everything. So that's teleclerkship on the wards. And now I'll just pass it to Amin to talk through several examples from UCSF and Berkeley.
Before we start with Dr. Azam, we had a question from the audience,
Okay.
Sean, which is there a telerounding resource for students to view, or are you seeing that done more locally?
Do you mean like a how-to teleround? Not now. I mean, we don't know yet. We're figuring it out ourselves. But and I can also speak to so there's Johns Hopkins Bayview. It's like a 500-some bed hospital, and then there's Johns Hopkins Hospital, which is like 1,000+ bed hospital, and they're like 3 miles apart, but they might as well be in different universes. Different galaxies, right? It can only be one universe. But so what I've been told is that at Bayview, the technology's worked relatively well, where they've been able to get into the room with the patient without a lot of difficulty. At Hopkins Hospital, there's been more difficulty sort of connecting with the patient through the phone. So, so I think we're actively troubleshooting a lot of the tech issues on this, and so so wherever you are, we can provide advice and a framework, but ultimately, like your tech may be different, and there'll probably be like a pilot and iteration kind of phase to work through.
Thank you. One more quick question before we move on to Amin, which is about HIPAA and FERPA compliance. So how do you keep that patient information secure in a telehealth setting? Yeah.
So now at Hopkins, even in the inpatient setting, it's become routine in the COVID era, strictly because of COVID. It's become routine for patients to sign like a telemedicine waiver. And so they've consented to participating in telemedicine. And this is because, again, whenever I saw my first COVID patients, and we actually see them, we speak with them remotely before we walk in the room. And I think even going forward, there's going to be for hospitalists or internists inside the hospital are going to be able to see patients, follow-up patients remotely. So there actually may not be any physician who goes in and sees the patient on a certain day. So just to brace for that reality, patients are now, again, all patients are signing up for like a telemedicine waiver. So they've consented to that. And then each of the modalities that we're using is sort of vetted for HIPAA compliance. So Zoom, from Hopkins' perspective, is HIPAA compliant. And telephone has been, anything we're doing through Epic is HIPAA compliant. So yeah, we've thought about it, and that's how we've dealt with it.
All right. I think, Catherine, I'll go ahead and move ahead to other examples, and we'll do some more Q&A. So, my name is Amin Azzam, as Catherine said. I am a psychiatrist by training, at heart an educator. I've been on faculty at UCSF in the School of Medicine, at UC Berkeley, UCSF in the Joint Medical Program in the School of Public Health, and at Samuel Merritt University in the Simulation Center, where my focus is interprofessional education. First, I'll just sort of do the same disclosure Sean did. I'm also working from home, and sort of same kind of deal where, you work from whatever space you have. So I've got this like space that's been converted into a clinical space where my wife and I both practice our clinical care when we can from home. So just to address some of the things that were already discussed in Sean's comments, UCSF has definitely moved to telepsychiatry or telehealth as well. Like the Johns Hopkins patients, my patients sign waivers or consents to participate in remote clinical providing care. And in my case, I run psychotherapy groups for patients living with chronic medical conditions. So we also have to make sure the waivers ensure that patients in groups are also not in public places where there might be accidental disclosure of patients' private HIPAA information. In any case, that's the clinical side. I'm going to now share with you some examples from my various educator hats from my different universities to get you thinking about the educator side. So at Samuel Merritt University, we run interprofessional education simulations with our sim center. And so we had these all set up to go before COVID-19, and the COVID-19 hit in the middle of our curriculum. So we had already planned to design the simulation with students actually working with standardized patient actors in the sim center. And when that became impossible, we moved towards virtual remote simulation. So what I'm showing you here is an example of a subsection of the timeline of the simulation, in which what we did was use historical footage that we had from last year's students with this same virtual scenario, the same standardized patient role. And then what we did with this year's students on the Zoom meeting was we literally said, all right, we're now going to advance the clock, and you are going to be the change of shift that's taking care of this same patient. So you had the privilege of watching last shift's team. You got better sign out than you would have otherwise, because you actually got to watch their care rather than hear them discuss their care. And now we'd like you to proceed with your care by doing a hallway huddle and how you as an interprofessional team are going to care for this patient. So you can see that the sim technology specialist had some specific instructions about muting and unmuting the actors' videos, and we discovered that Zoom has an ability to hide all non-video participants. So we actually literally, it's effectively like pushing the observer students and faculty out of the room so that you maximize the viewer experience of feeling like all of those students and those actors were actually in a conference room together, rather than the Zoom artificiality of everybody being at home. So we made it work. We ran over 100 students through the simulation over about 7 different sessions across all of the universities and students. And yes, there were technical hiccups, and yes, we struggled with some of those, but like all simulations, you learn as you go and you get better as you go. So that's one very specific example of a success doing institutional, interprofessional, remote simulation-based Zoom education. Okay, second example, this is from my Berkeley hat, the UC Berkeley, UCSF Joint Medical Program, medical students in their pre-clerkship years of medical school. And in this case, they are also developing a remote OSCE. I know that Sean hinted at that. There's definitely a lot of discussion around that with some of the educator listservs. So this is an example of a standardized patient script for the actors, just a sub part of that screen. And what I wanted to draw your attention to is the simulation itself. In the SP script, we're basically describing where are we simulating, and we're basically going to be simulating a telehealth visit. And so the patient would be calling from home. The medical student is going to pretend that they're either calling from home, just like Sean has described in the real tele rounds, or they can pretend that they're in a hospital setting. Some people are aware that Zoom has these simulated backgrounds where you can pretend to be in a different room. We're not asking students to do that at this point, but the point is students can pretend to be doing a telehealth visit with an actor who is playing the role of a patient calling in from home. And this one is going to, we're using the learning management system that Berkeley subscribes to, the Canvas course site. And so I wanted to just give you a hint as the educator team has developed in rapid fire ability to have students practice Zoom on their home device before their actual encounter with the actors. And so this is a chance to work out all of those technical logistics upstream of the actual event. And so really kudos to my Berkeley teammates who've done a really amazing job developing this, as Sean described with Hopkins, on very rapid timeline to make sure that it works. And this gives students a chance to still engage in clinical reasoning and history-taking interview component without the physical exam component. I would offer that for your programs, as is always been done long before COVID-19, if a student wants to perform a portion of a physical exam with a standardized patient actor that is invasive, long ago, simulation said you could tell the actor, I would now like to perform a pelvic exam, and the actor would say, the results are in the drawer, or here's the piece of paper with the results. So there's no reason you can't continue those kinds of simulated activities, even though you are now remote from the actor and not in the same room. Okay, third example, this is now my UCSF hat. So we've been running a Wikipedia editing course for med school credit for a number of years now. And this is offered through the Wiki Education Foundation. This is their equivalent of a learning management system. So this is a screenshot of my most recent cycle of my course in March of 2020. And you can see this, the course dashboard allows people to track the student contributions to Wikipedia. And so I had 7 students enrolled in my course. They were senior final year medical students, and the 7 students made 287 edits to adding 12,700 words to Wikipedia and 122 references. And those pages that they worked on, those 7 pages, were viewed 75,900 times just during the month my students were working on it. The course dashboard has lots of abilities to track and monitor your students. So these were the pages that my students worked on this last month. And on that far second to right farmost column, there's that little tool that looks like a piece of paper. And if you click on that, it allows you to track and sort of highlight the edits that your students actually make. So this is one of my students who worked on the central venous catheter Wikipedia page. And you can see that he made quite a few edits. So that's another possibility, is having students engage in remote care of virtual, if you will, real patients, real people reading on Wikipedia, but not actually doing clinical care. Fourth example comes from Oregon Health Science University. This I discovered through the Dr. Ed listserv. There's lots of different educator communities. I'll mention there's another one called DOCS, which is Directors of Clinical Skills courses in medical school. The Society for Simulation in Healthcare has a lot of listservs related to different types of health professionals using simulation. I'm sure some of you know some other listservs you'll tell us about in the discussion portion. Oregon Health Sciences University runs a course on biomedical and health informatics. They've been running this long before COVID-19. What I thought was really wonderful about this example, and I highlighted it for you here, was basically they opened up their course to students globally. And they said, dear beloved faculty at other schools, you manage your students. We'll run the course. You work out the academic credit at your institution. We'll have you run it. I mean, we'll have you participate in it. And then you work out all the academic details. And what I really love about this example is they're opening up their arms to other students without opening up their administrative team to the headaches of having non-Oregon students enrolled in the course. So a lovely example of sharing resources across institutions. Okay. All right. I think from here, I'm going to hand it back to Catherine. I'll stop sharing Sean's screen, and Catherine, take it away.
Wonderful. Thank you. So now we are at the discussion portion. So before we get started, we just wanted to provide some guiding questions, which you're seeing here as initial questions to ponder. These are things that we certainly discussed prior to this presentation, especially surrounding what does it mean to do clinical education in this scenario, and more broadly, how do we set the bar for that? How do we know what we're assessing and what's appropriate to assess? So we would love to hear from you. Please feel free to ask questions in the chat, and I can unmute you if you would like to share a story.
I will just answer in greater detail. There was a question a panelist asked me about whether we got permission from the historical students' video footage to share it with near peers. We did, and we only used one set of 5 students rather than getting a whole bunch of different historical footage. It was a lot easier and simpler to just get permission from those 5 students.
Excellent. We do have a question, which is, the challenge in South Africa is to reduce synchronous online teaching to the minimum due to bandwidth and access challenges for some students. Yes, we're aware of that. So are there particular examples of clinical online teaching that don't require people being online at the same time, using up that bandwidth?
Sean, you can go ahead and I'll answer first and then pass it to you. So in simulation land, there's definitely lots of examples of that. So there are different vendors or co-curricular content creators that have example cases online that students can work through on their own schedule. And then individual universities can assign students, for example, reflections on those activities that the students submit to their clinical faculty of record. So it doesn't require the clinician or the educator to be simultaneously or concurrently going through the online case scenario with the student. That would be an example where you're doing the entire simulation or asynchronously. I know that there are examples of that in nursing education, in physical therapy education, and some of the other health professions I've worked with. It all depends on what co-curricular content creators you have access to. If you have example cases in your own local institution, you could easily share that within your local technology architecture. And I think the key is for the educators to be writing some specific requests of the students that they reflect on what they did. That proves the students did it, it proves the students are thinking, and then the faculty can respond to the student reflection.
Excellent. There is a classroom, a question about YouTube for videos, or do you have suggestions of what they can watch, such as videos? Are there videos being filmed at Hopkins that are being shared out?
One thing I can tell you is that there has been an incredible increase in the amount of resources that are available for learning at home. I know the AAMC has tried to collate those. There's a website. We can maybe share it out after this. I think it's like iCollaborative. But there's as I've watched that website since it was launched, it's been growing in the amount of resources that it's sharing. I can share it.
Yeah, while you pull that up, I'll just answer some of the other questions that were asked me. So one about the challenges of training SP actors. We've been using Zoom to train our actors, and so you definitely want to have an upstream training with the actors. We used to do those trainings in person, now we do them on Zoom, so it's a simulation educator with the actor without students. If you have a simulation center that has the luxury of simulation technology specialists, then working with them also to train up those actors on Zoom or the video conference platform you'll use. Second question was around challenges with hiring actors. Again, my simulation center has already a mechanism in place to hire and pay actors. I would offer that a lot of actors are out of work right now because a lot of their other day jobs have gone dark. And so actors are actually really eager to do this kind of work. So I would imagine there might be a mechanism for you to find the actors. In terms of the payment structure, it would depend on your local context of how much actors are normally paid for doing this kind of standardized patient work. The cost was not trickled down to the students at all. The cost was borne by the institution that is hiring the actors. There was a question about OSCEs, and I'll answer this and then pass it back to Sean to go over the iCollaborative resource. So there's been a lot of discussion on the Dr. Ed listserv about OSCEs and how institutions are converting to remote OSCEs and to secure and how to make sure they're secure. I've followed some of that discussion. I would just say that a lot of the different elements are very much up for renegotiations in this era. So we've seen examples of OSCEs that have reduced the number of stations, to reduce the complexity, and OSCEs that have reduced the security issues, OSCEs that have designed ways in which students are participating remotely, but still with a, if you will, proctor, a faculty proctor who's watching in live real time, so you can tell the student if the student were to try to take screenshots or to try to step off screen. So there are lots of creative ways people are doing to address OSCEs while still trying to run something like what used to be an OSCE. Sean, to you.
Yeah, so I'll just show, some of the websites. Again, there's just been too many to even shake a stick at, but these are like some nice collations. So iCollaborative, and the way they've organized it are around like the ACGME competencies. So this for interpersonal communication, medical knowledge is a lot. Patient care, so-called patient care resources, practice-based learning improvement, professionalism, system-based practice. And there's overlap. So, some of these are in multiple different categories, but spending some time snooping through these could give you some ideas. This is the one I was referring to about the ICU, like tele-ICU rounding. So there's a video in here that describes how that's being done at Hopkins. And then this is a weird but good, this is a Google Doc that people have kind of created. And so it gives kind of like, it has a lot of information related to student volunteering, but then also talks about student learning and the like on the wards and other like clinical kind of learning. And then I found this one, again, this is my internal medicine world. The Alliance for Academic Internal Medicine has put together this list of COVID-specific sites from these different organizations. So just clicking through here, I found the ACP stuff to be really helpful when it's free and pretty comprehensive. So these are just other, and AMA is doing a good job with this. So, these are other resources that you could spend some time with.
There's one question in the chat about sort of distance manual procedure-based simulations or activities, and from Stacy Hunt. I wanted to just encourage Stacy to think creatively here. I'll share, for example, as a non-clinical example, my kids are being homeschooled, of course, like a lot of other kids. And, my kid has a music class, and so the teachers produced a video of her performing on a ukulele. And she's asked all the students to find some sort of musical instrument at home that they can play along with or drum along with. And she said very clearly, if you don't have an instrument, a pot lid will work just fine. Be creative with what you have. Why do I use that example? You talked about medication reconstitution. I completely get that you can't expect students to have the ability to do that manual dexterity task at home. On the other hand, there's probably resources that are low fidelity ways to simulate medication reconstitution at home, where the students might even be able to video themselves with their low quality stuff to demonstrate to you that they've tried some manual dexterity task that you could then see that they're trying to simulate. And then if you actually invite the students to figure out the ways that they're doing this task, they will build the fidelity together as they improve the sort of particular things that are necessary for the task. So that might be an example of ways in which you can leverage your students' creativity in designing scenarios or manual dexterity tasks from home. Catherine, I don't know if there's other questions you wanted us to address in the chat. Thank you for moderating the chat.
Zakia Demasi asked a question, which I did attempt to answer, about using managing simulations or clerkship experiences when the bulk of what we're seeing right now is COVID-19 related. My sense is that we always see a seasonality in flu or gunshot trauma. There's a seasonality to how things show up in the emergency department in practice, but I wonder if you could speak to ways to mitigate that in learning.
Again, I'll answer first, and then Sean, feel free to chime in. So to really agree with Catherine's point, even pre-COVID-19, there was always seasonal variation in the demographics of inpatient or other sort of disease presentations. So, the argument here is students get it over time across the longitudinal arc of their curricular experiences. Certainly, there have been a strong desire to minimize inpatient care of diseases other than COVID-19 to create space for the surge of cases of clinical COVID-19. So, some health institutions and some accrediting bodies and some organizations are reducing the expectation of the volume of clinical activity that students should be expected to see. Obviously, we need to make sure we have a minimum bar of what students must see. And so those accrediting bodies determine that in the minimum bar. They may be lowering it a bit, but not way down. And so there may be some wiggle room in terms of allowing students to have a lower diversity of clinical experience and yet still complete their training. I also think that when, not if, but when we get past this global pandemic, whenever that happens, those accrediting bodies will likely look for examples in which students can downstream make up some of the missed stuff. Sean?
Yeah, and like everybody said, you can have simulated cases to make up for things you actually don't see. And the accrediting authorities tend to be pretty flexible with exactly how the spectrum of different clinical scenarios are addressed by schools. Again, from a medicine side, but this is probably true of almost any specialty. A patient with COVID doesn't just have COVID in the vast majority of cases. So they're going to have comorbidities, and you're going to have to manage not just the COVID, but their other comorbidities. And so even if it's not a chief complaint of heart failure, they have to manage heart failure. And so just logging those conditions. So you find that students actually have, even if chief complaint, I guess, is COVID for a disproportionate number of patients, you end up managing quite a wide spectrum of illnesses.
I think we are caught up on questions. Peter Fischoff says, "Stop touching your face, Sean."
I'm not touching over here or here.
Thank you, Peter, for teasing us. I wanted to acknowledge that there are a lot of resources out there. We have deliberately not been promoting the Osmosis resources specifically because we wanted to be platform or agnostic, if you will. We're wearing our academic hats today. We are both, as you saw in those sort of title slides, affiliated with Osmosis. I would just add that there is a resource for educators. The Osmosis has a landing page for resources for educators that are Osmosis produced. But just like you've seen in the chat feature, lots of you are sharing other resources that are aggregates of different high quality resources. Like all consumers of information, we as health educators need to be aware of the sources that we're seeking, and we need to make our own independent judgments of how reliable we think those sources are. So, as you all start to shop for either content that you want to use in your local context and or resources that are co-produced or what is called co-curricular content from individual producers of content that are not other universities, just remind you to think carefully and deliberately about what your learning objectives are, what you're trying to achieve, and whether those resources meet your needs.
Thank you. We have some questions through the question and answer feature. So Mitzi Scott asked if we have any creative suggestions for students to practice physical examination skills. I'm home with a 17-year-old and a 13-year-old, so I could certainly practice pediatric and adolescent medicine physical examination.
Catherine, I'll take a stab at that too. So when my kids were younger, I did used to bring them without their permission to my medical students to teach the sort of like developmental milestones. And so obviously one gets creative and in your educator hats. Long before we had standardized patients, long before we had mannequins and simulation, students would practice their physical exam skills on each other. I know there are risks associated with that, and so I acknowledge you need to be very careful about that. But I think you can create suggested guidelines around it, and as long as you as educators ensure the safety of your students, that's what we're doing by having students not be on clinical COVID-19 sort of clerkships or clinical rotations or clinicals. As long as you ensure the safety of your students or you do your best to ensure the safety of students, you can get very creative with physical exam skill techniques that are non-invasive. For places that are allowing simulations to occur or simulation centers to continue, then you still have the advantage of mannequins and standardized patients.
Yeah, and even if you're by yourself, if you have access to somebody who is with somebody else, you can talk them through a physical exam maneuver. So the only thing you're missing is that tactile aspect of it. So you can do, again, almost everything remotely.
Great suggestion. So Lorna Weisbrod asked, in nursing ed, what percentage of face-to-face with patients clinical learning hours is acceptable to transform to the virtual and distance learning approach? And have we seen any guidelines from the literature?
I can tackle this one.
Perfect.
So it was Samuel Merritt. It's a nursing school here in San Francisco Bay Area. The California Board of Nursing is responsible for declaring what fraction of simulation is acceptable for clinicals. Prior to COVID-19, that fraction was set at, it's 75% of the clinicals need be actual clinical encounters. And then the California Board of Nursing has lowered that bar to 50%. So that means then, therefore, that up to 50% of clinicals can now be replaced with simulation. Different health professions have different bars on that. I know that physical therapy has a different bar, and you can see some other participants sharing their experiences in their local. So thank you, Martha, about Maine's being 50%. So I think that there isn't, to my knowledge, any literature about that. I haven't personally looked for the literature on that. And even if there is literature, it's all pre-COVID-19. And so I think the COVID-19 pandemic is appropriately asking accrediting bodies and licensing agencies to reassess their prior bars. And so I think that those institutions are generally conservative and they may move slowly, and a global pandemic is a challenging time to move quickly. But I would suspect and anticipate that a lot of the accrediting bodies are going to modify their bars to allow for flexibility as each institution and each health profession designs creative ways to address clinicals.
Wonderful. We got another great question, more of a comment, that emergency online teaching, which we're now starting to call ERT, emergency remote teaching, is causing anxiety for students and teachers, and that many of us aren't comfortable teaching remotely. So I think that nods to a really important question about, are we doing distance learning or are we doing emergency remote teaching? As an instructional designer and educator, I would say the answer is we're not doing, by and large, very good distance learning yet, because we are learning, right? When we do something quickly, we just don't often have the infrastructure in place to line up those assessments. Sean, do you have anything?
I think it's a lot of time to be nervous about failing. You know, I think just nobody's going to judge you. Well, my personal point of view is that we shouldn't be focusing on what the judgments other people might be passing on us at a time like this. We should just be doing the best we can, and come what may. And so I think that's where this I'm scratching my nose. I'm sorry. But I think that's where this tension between, like, is it emergency remote teaching versus is it online learning? I mean, it's online learning, right? It is, but it's very bizarre and hastily put together online learning. So it's not the best of online learning. It's online learning, though. And I think as long as we just recognize that there's a nuance there, then people will be okay with it. But again, I think everybody's nervous about everything these days. And all we can really do is sort of take things day by day and do the best that we can with the role that each of us has. And I think, to the extent we can also forgive others if we think that maybe they're not doing as well. Again, I think this is hard, and I think that do the best you can, and don't worry so much about the judgments other people are going to pass, as long as just because this is just hard. So
totally agree with Sean. I'll make 3 points. First, in terms of our own well-being as educators, I did produce an Osmosis video that's free on our YouTube channel about taking care of ourselves so we can take care of our students, and some suggestions on how to do that. As to that sort of what do we call it? The sort of imposter syndrome or fear of failure as educators. Look, we all know from our own experiences that innovation takes a lot of time, and you don't hit it perfectly the first time out of the box. So I remember years ago learning what I was taught was called the 70% rule in medical education. I think this applies in other health professions education. If you get an innovation up to 70% of what you want it to be, go ahead and launch it, because thankfully, in health professions education, when we make mistakes, it's not life or death because it's not real patients, thankfully. And the other good news is that we get to iterate and improve our innovations for the next cycle of students. So we will improve it. And if we waited till we got it to 100%, that last 30% would take so long, we wouldn't innovate. And again, we can, Sean's right. Like, our students get that this is unheard of. None of us have done this before. None of us have lived through a global pandemic before. So I think being permissive of yourself to try and stumble, and we say in simulation, I think this is true in all of our work, when we make mistakes in simulation, they are not crimes to be punished, they're puzzles to be solved. And the same could be said for all of our innovations in emergency remote teaching, or in online or flipped classroom, or converting what we used to do to what we're doing now. Really, a part of our goal here in giving lots of space and time to the participants was to hear your examples, so we can all let those creative juices flow from this discussion.
I think we are caught up on questions, unless Tracy, McCaig, Beatty would like to talk, and if so, I'll figure out how to unmute you, Tracy. There was a question about how nursing programs are approaching this, and she said that they're using Zoom to work through online simulated experience for nursing experiences. And having the students create teaching videos to demonstrate skills on what they have available themselves, their children, dolls, stuffed animals, etc. Did you want to add some more color to that, Tracy? I think that's lovely. I put you on the spot.
Can you hear me?
Yes, wonderful. Hi.
Hi. So I'm a nurse educator from Saskatoon, Saskatchewan, Canada. And of course, we did a lot of this on the fly, but again, doing the best with what you've got, and finding out how many amazing resources are actually available out there, and even just tweaking them to meet your own needs. So I wasn't exactly 100% on board with potentially some of the resources that our university chose to utilize. Because I felt that there were better resources out there that I could utilize, but I did take what we were allowed to use and then tweaked it to meet our own needs. So there was some great simulation events that we used that could simulate a number of things. So for instance, in nursing, one example that I'll just speak to was a child with, I teach pediatrics, so a child with meningitis that a medication error was made on, and then the whole process of reporting a medication error and working through, of course, an assessment of a child with a neurological disease. And so I just created, kind of using the simulation and the premise of the simulation to create a PowerPoint with visual cues to help my students work through a neurological exam, to look at the safety of the setting when they walked in. So of course I found a picture that had a child in a bed that had a ton of toys and no seizure precautions in place. So they had to pick up on the fact that there were no seizure precautions in place, what things they would be looking for. And then we went on, and it was actually amazing. Almost all of the students made the medication error because they didn't look at the medication label that was put up on the screen to do their 3 checks. They all explained to me that they would do their 3 checks and all the different moments of right medication, but they all made the error because when they were looking at the screen, they didn't pick up on the fact that it was the wrong antibiotic, which was really valuable for me, and I think an amazing lesson for them. Not to assume that the medication that is being given is the correct. We're also dependent on technology and not looking sometimes at the obvious, and that is the picture that's right in front of your face. So there was some great learning experiences that came out of that. And then the creation of assignments and I was amazed because my students are all at a distance, how they collaborated and worked together to create a teaching video for children based on their different growth and developmental needs. So they had to take that knowledge of, how would you speak to adolescent versus a preschooler child to teach the very same specific entity kind of thing. And so they created these amazing videos where, like a puppet show for preschooler and school-age children to teach them about germs and washing their hands. Like it was actually amazing at where the students went with things. And then there were some other opportunities where they could potentially look at creating policy, which they never get the opportunity to, but we teach them that they need to do it. So yeah, there was lots of, and that's only the tip of the iceberg.
Thank you for sharing that lovely story. Amin, did you want to respond? And then we'll do a wrap up as we are at the top of our hour.
Sure. Tracy, again, thank you. One comment you hinted at, as individual faculty, you have like individual resources you might recommend, then of course ones that you are subscribed to or your institution subscribed to, and what your resources your institution endorses versus allows. And so obviously there are layers of that, but I think innovative faculty can seek resources. There's this joke in medical student education in the United States that every med school suffers from the NIH syndrome, or not invented here. And the problem is we've all been teaching and working in isolation, and the more we distribute and collaborate, the better, and the more we share resources, the better. Catherine has asked me, I put my email in the chat. I wanted to let you all know that we do have an Osmosis listserv that we curate of educators at institutions. And so if you'd like to join that, we may be able to use that to continue to share stories with each other of best practices and innovations and lessons learned in our own innovations. So I think, Catherine, we're going to turn it back to wrap up, and I forgot exactly what we're doing with wrap up, but I know you remember. So let me pass it back to you.
Excellent. So Sean, if you'll bring us to the next slide. So first, thank you. Thank you everyone for joining. We hope that you'll join us next week. We'll be talking on Friday about raising the line, academic productivity and personal well-being for educators during COVID-19. So we would love to have you back. If you have any questions, if you want to join the listserv, Martha, I see your comment. Please email me, Catherine, on the next slide, sorry, Catherine at osmosis.org. We wish you health, and thank you again.
For more info, visit our medical educator page at osmosis.org/educators.